my name is Querijn van Bokhorst. I am a research fellow at the Department of Gastroenterology and Hepatology of the Amsterdam University Medical Center in Amsterdam, the Netherlands. On behalf of all authors, I would like to thank Endoscopy for the invitation to discuss our recently accepted paper entitled Delayed Post-Polypectomy Bleeding Following Cold snare Polypectomy of Lesions Smaller than 10 mm in Patients on High-Dose Antithrombotic Therapy. Insights from a Dutch colonoscopy cohort. The use of antithrombotic therapy is known to increase the risk for delayed post-polypectomy bleeding. To reduce the risk for such bleeding, the current BSG and ESG guideline recommends discontinuation of all types of antithrombotic therapy whenever polypectomy is performed. This excludes cold snare polypectomies of lesions smaller than 10 mm, for which aspirin or clopidogrel monotherapy may be continued. As such, low-risk polypectomies are generally considered safe in patients on continued aspirin or clopidogrel. These agents may also be referred to as low-dose antithrombotic therapy. Meanwhile, antithrombotic therapy consisting of a vitamin K antagonist, direct oral anticoagulant, or dual antiplatelet therapy is recommended to be discontinued if a polypectomy of any type is performed. These types of antithrombotic therapy regimens can therefore be referred to as high-dose antithrombotic therapy. As guidelines recommend routine discontinuation of high-dose antithrombotic therapy around colonoscopy, the risk of delayed post-polypectomy bleeding with continuation of these agents is uncertain. Continuation of these agents may, however, yield significant clinical benefits. This predominantly relates to the relatively high incidence rate of thromboembolic events in patients discontinuing high-dose antithrombotic therapy, as reported in earlier studies, with incidence rates ranging between 0.9 and 4.6%. While the bleeding risk for cold snare polypectomies of lesions smaller than 10 mm is known to generally be low, it can be debated whether the potential harms associated with routine discontinuation of high-dose antithrombotic therapy do outweigh the increased risk for delayed post-polypectomy bleeding associated with continuation of these agents. In order to obtain additional insights on this topic, in the current study we aim to evaluate the safety of performing polypectomies in patients on continued high-dose antithrombotic therapy for cold snare polypectomies of lesions smaller than 10 mm specifically. To do so, we analyzed data from all colonoscopies performed at 2 Dutch outpatient colonoscopy clinics between January 2017 and January 2024. Data from these centers provided a unique opportunity for obtaining insights into the risk for delayed post-polypectomy bleeding, as both centers follow different protocols for the management of antithrombotic therapy around colonoscopy during the complete study period. The management of antithrombotic therapy particularly differed between both centers for diagnostic colonoscopies other than colonoscopies after a positive fecal immunochemical test for the colorectal cancer screening program. In Center A, for these procedures, high-dose antithrombotic therapy was routinely continued. In Center B, high-dose antithrombotic therapy was routinely discontinued or switched to low-dose antithrombotic therapy. The primary outcomes of our study involve the incidence rates of delayed post-polypectomy bleedings and thromboembolic events for patients on different antithrombotic therapy regimens, including those continuing and discontinuing high-dose antithrombotic therapy around colonoscopy. Then, for the results. In total, 31,325 colonoscopies were included, in which over 51,000 polypectomies were performed. In 12,291 of these procedures, only low-risk polypectomies, defined as cold snare polypectomies of lesions smaller than 10 mm, were performed. When evaluating the incidence rates of delayed post-polypectomy bleedings for colonoscopies during which only low-risk polypectomies were performed, we observed an incidence rate of 0.07% for patients without antithrombotic therapy, 0.30% for patients on continued low-dose antithrombotic therapy, and 0.58% for patients on continued high-dose antithrombotic therapy. No statistical difference in the delayed post-polypectomy bleeding incident rate was found between patients on low-dose and patients without antithrombotic therapy. Moreover, we did not observe a significant difference between patients on high-dose and low-dose antithrombotic therapy. Meanwhile, a statistical difference was found in the delayed post-polypectomy bleeding incident rate between patients on high-dose antithrombotic therapy and those without antithrombotic therapy. However, it should be emphasized that the incidence rate of post-polypectomy bleedings for patients on continued high-dose antithrombotic therapy was still very low at 0.58%. Moreover, the absolute risk of delayed post-polypectomy bleeding was found to only be 0.67% higher for patients on high-dose antithrombotic therapy compared to patients without antithrombotic therapy. This translates to an estimated number of 150 patients that would have to discontinue high-dose antithrombotic therapy to prevent one case of delayed post-polypectomy bleeding. In other words, 150 patients would have to be exposed to an increased risk for thromboembolic events to prevent one case of delayed post-polypectomy bleeding. For patients discontinuing high-dose antithrombotic therapy or switching high-dose antithrombotic therapy to low-dose antithrombotic therapy, the incidence rate of thromboembolic events was 0.18 in our study. While this represents a relatively low incidence rate compared to earlier studies, which may be attributable to the outpatient colonoscopy population with relatively low comorbidity burdens, these events could likely have been prevented if high-dose antithrombotic therapy was continued. So, in conclusion, our study highlights that the risk for delayed post-polypectomy bleeding is comparable for patients on high-dose and low-dose antithrombotic therapy. Moreover, although the risk for delayed post-polypectomy bleeding is higher for patients on high-dose antithrombotic therapy compared to patients without antithrombotic therapy, the absolute risk for delayed post-polypectomy bleeding remains very low, even on continued high-dose antithrombotic therapy. As such, discontinuing high-dose antithrombotic therapy may not outweigh the benefits of continuing high-dose antithrombotic therapy around colonoscopy. Based on our study findings, we suggest routine continuation of high-dose antithrombotic therapy for colonoscopy indications carrying a low risk of detecting advanced polyps, while routine continuation of low-dose antithrombotic therapy should be considered for all colonoscopies. This may improve clinical outcomes and ease management of antithrombotic therapy around colonoscopies. Thank you very much for your attention.